My name is Maurice Garcia. I'm a board-certified urologist specializing in genital reconstructive surgery and sexual medicine. I'm faculty at Cedars Sinai Medical Center in the Division of Urology, and I direct the Cedars Sinai Medical Center Transgender Surgery and Health Program. I founded it in 2017, and it's an interdisciplinary program comprised of faculty specialists in all domains that provide care and services to transgender and gender nonconforming people. So it's not limited to genital surgery. On the contrary, it includes specialists from a variety of domains, including mental health, internal medicine and primary care, dermatology, as well geriatric medicine, adolescent medicine, as well as surgical domains, including genital surgery, plastic surgery, facial and feminizing surgery, gynecologic surgery, as well as hand surgery and other specialties. An academic center-based transgender program has the benefit of delivering care for whatever specific area, domain a patient seeks, but within the context of a multi or interdisciplinary program where should the patient need or benefit from services from another provider, they can easily be obtained. Sometimes it's necessary or useful to get advice from a provider from a different special area of medicine and surgery. That can all be easily delivered effectively essentially under one roof. Another benefit to an academic center program, one of the ways in which we stand out is that we have an active research department. So clinical and basic science research, not only in my field, but in the fields of my colleague specialists. The third benefit is that we have our entire hospital is dedicated to seeing the program succeed. And success is really defined by giving the best patient care possible. So that includes not only the services that we provide with our minds and our hands, but the care given by our nurses, by our front office staff, by our Department of Radiology when they see a patient for an x-ray. People are addressed in a culturally sensitive, respectful way that, unfortunately, a lot of transgender and gender nonconforming people will say that their experiences in the medical care environment are often marred by bad experiences where people speak to them using the wrong pronouns or disrespectfully or they're biased, et cetera, et cetera. So our whole institution is really behind this program. And I think it shows in not only the level of care, but the quality of care that and the way people are treated in our home at Cedars. There are various potential pitfalls to delivering quality and respectful care to transgender and gender nonconforming people. I think that these start when the patient opens the door and sets foot on the campus or building or office where they're going, how people are addressed and spoken to. We go to great lengths to ensure that people are spoken to and they have a gender-affirming experience. Things like the pronouns that staff use and providers use, these should be the correct pronouns. So how do we use correct pronouns? Well, it all starts by asking. So our intake forms have a space for preferred name and the gender that they identify with. And this information is passed on once we collect it from a form, or the front desk office person may ask these questions and write down the answers. We make sure that those answers, the preferred gender or the identified with gender and the preferred name, are transmitted to their medical records. Basically, everywhere in our medical center where our patients leave a footprint, where the different departments and places they end up visiting. My office or our offices, the other providers, the preoperative area, the operating room, the recovery room, radiology, the hospital ward, etc. People should should be versed in correct terminology and respectful, just the basics of respectful communication. At one level, I direct the program, so I am responsible for the overall quality and comprehensiveness of the program. It's my responsibility to make sure that we're all giving good care and that we offer a breadth of care. Another responsibility with that is to make sure that we, all of our faculty and our members of WPATH, we attend local and regional and international transgender care meetings. We're basically up to date with, just like any area of medicine, providers need to be up to date and need to know what's going on, what are the latest sort of breakthroughs, what are the controversial areas, and so forth. And then I oversee things then just specifically pertaining to my practice. I'm in the division of urology. We offer care for transgender men, women, and non-binary individuals. So we offer masculinizing and feminizing surgeries. Any surgery that can be obtained anywhere in the world, we offer at Cedars, Sinai. Any genital surgery, we provide. I am often, not always, but often the very first point of contact for transgender people into the services of our program. They are referred directly to me by providers or they're self-referred. I meet with them and go over all options available to them. That's a discussion that we can only have after I've learned about them. So I have a fairly detailed intake, interview and discussion where I need to learn about the patients as people and what their medical histories are, and what their goals are with surgery. Sometimes learning about these goals can lead me to discover that what's most important for them is not genital surgery, which is what I offer, but let's say facial feminization surgery or gynecologic surgery or removal or augmentation of their chest. When I do this, of course, my responsibility is to refer them to the providers in our program that can suit those needs. So I think an important lesson is that for any surgeon of any particular field is that patients may prioritize the services that we as individual surgeons offer differently than we expect. And I think to give good care, we have to be listening for that. And when I'm alerted that someone wants something different from what I do, well, my job, my responsibility is to help them get that. So I refer to my colleagues. I have very good, close working relationships with all of the faculty in our program, and I make sure I close the loop, refer them, maybe talk to the provider, introduce the patient, tell the patient about the provider, and so forth, and pass them on. And when they're ready to undergo something that I offer, I see them. During that first visit, it's very important to cover any and all surgical options. A lot of patients today with the internet and many feel very knowledgeable about what's out there, what surgical options they have. But the mark of an innovative program is that you offer innovations that many people aren't going to be aware of. And the reality is that some patients may be not as informed as they think they are. So I think it's very, very important on the initial visit or visits, to cover any and all options available to someone like them in a general sense. And then, of course, second with that is that we listen to what the patient is leaning towards or wants, and then we quickly cone down on that particular type of surgery, for example. But at least we've covered in general terms the other surgeries that are also available to them. I think a first visit, it's very, very important to cover not only all of the options, but all of the risks and the benefits that go with those options. Not only risks at the time of surgery, but long-term risks or potential for complications. I think it's also very important to cover more subtle, complex areas of decision-making. So for example, a particular surgery like phalloplasty, urethral lengthening is an option. It doesn't have to happen with phalloplasty. But some options preclude other options. So without vaginectomy, with a phalloplasty, the risk of urethral strictures and fistulas can increase. So we need to explain to patients not only all of the options and the risks, but how those options and risks fall into place in a kind of interdependent way. And that is honestly can be very complex and sometimes confusing to patients. So it's my responsibility to present things in a way, in an order, and organized in a way that patients can understand it. I think it's also very important in a clinic visit, patients have a lot of emotions going on. They're getting a lot of information thrown in their direction. It's hard for anybody to keep everything straight and remember everything once they leave. So I think it's of utmost importance that all patients have a minimum one additional visit before surgery to allow them to digest the information that they heard at the first visit and come up with questions or concerns or ask about other options, whatever it is. This is all often, I think for most people, way too much to kind of process in one visit and make a firm, informed decision in one visit. About half of my practice is tertiary care. That is, caring for patients that have had surgery elsewhere and have had complications. Sometimes they've only had the first stage of a surgery and want an additional stage, but for the most part it's complications. Urethral stricture with phalloplasty, fistulas, loss of vaginal depth after vaginoplasty with creation of a canal. These are all things that are urgent for patients and are important. There are many other little complications that patients can have, both little and big. But if they're important enough for the patient to seek care, I offer comprehensive care. So about half of my practice is tertiary revision surgery. And we are seeing a huge volume. When I started my practice at UCSF, where I started our genital gender-affirming surgery program in 2014, I was seeing a lot of patients that ran the gamut from young to old, but I was seeing a fair number of older adults. That is, people in their 70s, late 60s to my eldest patient was 81 at UCSF. And I think now that in just the last few years, people have, as care has become more available, particularly in California and other states, where the right to gender-affirming care is protected by law, and states whose Medicaid programs cover it. And the states have providers to offer care under public insurance and commercial insurance. But now I'm seeing a lot of younger patients. I think it reflects two things. One, changing cultural mores. That is, our society has become more accepting of transgender people, which is a wonderful thing. I think simply talking about it in the media, TV programs, interviews of well-known people and less known people, bringing this to the common person that may not know a transgender person, I think is helping people just become more open and accepting of it. They see the underlying basic right to being happy and being who they are. And our society is providing that. So now younger people feel more empowered and their parents feel more empowered to bring them to centers, not just mine, but other centers for care. At Cedars Sinai, we have a program that I'm especially proud of, and that is we have an adolescent transgender care bridge program. That is, it's a program dedicated to providing information and education for transgender youth and their parents, who are in many ways sort of the second patient in the room because they're responsible for their children. I firmly believe that kids need a place to go to, and their families need a place to go to learn about what options exist. That doesn't mean we operate on small children. We certainly do not. But even adolescents at age 17, the year before college is actually a very good time to undergo gender-affirming surgery for those that want it. Going to college, wanting their surgery it's very hard and not getting it is very, very hard for young people. So, we do operate on people under 18, but fairly close to 18. But that doesn't mean that people younger than 17 and so forth or 16 shouldn't have any place to go to learn about care. So I see patients as young as 8, 9, 10 that come in with their parents and want to sort of know more about what lies what can lie ahead for them. Of course, the nature of the discussion about surgery is different with a small child, with a very young person. But I think what shouldn't be different is reinforcing that there are options for them down the road and that there's hope. That's very, very important. My group has done work, and we've submitted it for publication, on the earliest ages that people report experiencing gender dysphoria. And about 80% of the patients, the adult transgender and gender nonconforming patients that we have, report first experiencing gender dysphoria between ages 3 and 7. Interestingly correlates very generally to the ages of first memory. So I think what I draw from this is that people live with gender dysphoria effectively their whole lives, as much of their lives as they can remember. Because of that, it's important to offer them care as early as possible. People shouldn't live with despair and a sense of hopelessness. Another aspect of our Adolescent Bridge program is that I communicate very closely with the people that almost always refer these patients to me, which is their pediatric domain, youth or adolescent providers. They send the patients to me, and then I talk to the providers and close the loop. I think care of the young or the adolescent or youth transgender patient has to be held to a higher standard, the highest standard possible as compared to even adult medicine, because they're a vulnerable population. So it has to be very interdisciplinary. And I think whenever possible, it has to involve the parents or their guardians. But their pediatricians, their endocrinologists, whoever's active in their care, we should all be one team, not just I'm one of the providers, and I should never operate independent of everyone else. I think operating together, working together, ensures the best possible care for these young people, and I think it's very important. I think the lesser educated members of our community and society assume two things. One, it's a choice, and two, that it's about sex. And my experience is unequivocally no to both of those. The best way I can describe it is it's a must. All of us feel we have no choice but to be ourselves. And if we assume that as a true statement, then people whose gender is not reflected in their body, meaning whose gender does not match the way their body is. I think it's important to remember not all transgender patients ultimately seek genital surgery. Some people can be comfortable living the way they are, but they almost always express themselves as who they are, even if they express themselves in ways that aren't mirrored by their society, their culture's gender roles. Bottom line is people need to be who they are and live who they are, and for many that includes surgical modification of their bodies that when their bodies are of the wrong gender than what they are inside. A lot of patients undergo genital gender-affirming surgery, not necessarily for anything sexual, but simply to be intact, to be for them, for those that have chosen it. Again, not everybody chooses it, but for those that do choose it, having genitals in line with their gender is simply a way of being complete and whole and who they are. Genital gender-affirming surgeries really have two principal goals and purposes. The first is to get rid of the anatomy that doesn't belong there, that should not have been there all along. And honestly, patients will tell you it's anatomy that causes them great distress. And identifying as a woman, but being born with male genitals is a very confusing and can cause a lot of distress. It feels like something can be very wrong with your body. So that's one goal of surgery. The second is to create anatomy that is in line with their gender for the reasons I just explained. First, simply to be whole and normal. You want to be a normal woman or a normal man. And secondly, to be able to have sex and sexual activity. But let's remember, sex and sexual activity is actually a fundamental part of just human intimacy. I think a lot of transgender people and gender nonconforming people will tell me that if they're uncomfortable with their body, it's very hard to enter into relationships because there's always that tension that should the relationship turn physical, they're going to have to perform physically using a body that they're not at peace with, they're not comfortable with. And that, for the individual, is a huge barrier and a huge source of distress. So I think it's important to put genitals into perspective. Genitals aren't only about sex. In fact, I would argue having correct genitals is more about being who you really are in all ways, physically included, and also being free to engage in relationships and be romantic with people and not have to worry about a part of one's own body having to be off limits because they have such negative feeling towards it. Genital surgery is often one of the later aspects of gender transition. A requirement for gender affirming surgery is that patients have lived and they're identified with gender role for at least a year, and that they have been taking hormones in line with their gender for at least a year. And thirdly, that they be thriving in their gender transition. It's at that point that genital surgery comes into play. So I think for many patients, it's a very important kind of end stage for their gender transition. It's one of the later things that remains to be done and to put behind them. So participating in that and offering that for them is very important for them and very fulfilling for me. A very important surgery that we offer trans-feminine patients is vaginoplasty. And I think it's very, very important that, as I mentioned earlier, that when we meet patients and offer them, discuss surgery, that we offer comprehensively all surgical options. I don't think a provider should ever make assumptions about the person in front of them, particularly when it's their first visit and we're talking about options. I don't know them and their preferences and what they may or may not want. So the safest thing to do is to cover any and all options. I think a very important option that I see not offered commonly is vaginoplasty without creation of a canal. So as I explain to patients that are seeking vaginoplasty, the goal of vaginoplasty, there's two goals. One, getting rid of the male anatomy that doesn't belong in their genital area. And two, creating feminine anatomy that they should have had all along. A vagina can include a vaginal canal, or it cannot include a vaginal canal. And I think that it's important to offer the option of doing vaginoplasty without creation of a vaginal canal for several reasons. One, there are many patients who don't plan to use their vaginal canal. They're not sexually active or don't plan to be sexually active. And therefore, having creation of a vaginal canal, there's a slightly longer recovery period. There is the burden of having to dilate and douche the vaginal canal, which exists for anyone who wants a vaginal canal. They have to be willing and committed to dilating and douching it long term, that is lifelong. And that can be very burdensome for people, particularly people who don't plan to use it. So the people that may want a vaginoplasty without creation of a canal could include people who aren't sexually active or people who don't plan to have sexual activity with men. We have to recognize that people who have only female partners may want to put toys or insertables. That's a part of sex. So they may still want to have vaginal receptive sex. And that's a reason to create a vaginal canal. But for people who don't plan on any vaginal receptive intercourse, it's an option that many of these people find quite attractive. Thirdly, people who, due to physical limitations, back and neck, simply can't move enough to perform the routine care of a vaginal canal that they'd need to. I explain to people what vaginoplasty without a canal offers, and it offers a vagina that outwardly is indistinguishable by appearance to a vagina with a canal. The only functional differences is that they don't have the canal itself, which is a place to insert anything, a penis or a toy. For trans-feminine people that have undergone vaginoplasty, talking to them after surgery, this is vaginoplasty with creation of a canal, they report that that nearly all of their sexual sensation is on the outside of their vagina, in and around their clitoris and other aspects of the outside of their vagina, what in medical terms is the vulva. The vaginal canal typically does not offer independently any significant amount of sexual sensation. It is possible to stimulate the prostate area through the vaginal canal, and for some people that can be very gratifying. But short of that, the canal itself functionally doesn't contribute to the majority of their sexual sensation, which is almost almost completely on the outside. I think offering vaginoplasty without a canal is important and should always simply be covered, full stop. It's for patients to decide what option suits them best and reflects their needs and fulfills their needs best, not for a provider. For these reasons, I believe vaginoplasty with and without a canal is a single topic, and that both sub-options need to be covered. My work doing what I do is incredibly fulfilling. I still am a urologist. I do general urology and sexual medicine and take care of many cisgendered patients. But my practice is almost exclusively now, over 90 to 95%, oriented to the care of transgender and gender nonconforming people. And I'm very, very happy with what I do. It's fulfilling on several levels. First of all, as I tell people when I give talks, transgender medicine really calls and touches on a lot of the reasons why most of us became doctors. We like people, and it's very personally fulfilling to help people. And helping people with their transition, either indirectly by referring them to my colleagues and making a program, or care by the surgeries that I do with my own hands, is enormously fulfilling. Another aspect of why I like so much what I do is that I get to have long-term relationships with my patients. When I do genital surgery, I tell them, look, you can see anyone else you'd like long-term, but I'm always here, and there's no one better to see you for any long-term issues about the genitals that I made than me, because I did it. I think making a difference in people's lives, it's hard to describe that. You can't rate it other than one of the best things that I can experience on a professional level. I think this field is also one that's really ripe for with opportunities for innovation and for advancing the field. It's a new field, and I believe firmly that this field needs to and will be as developed a field as any other area of medicine. Cardiothoracic surgery, neurosurgery, urology, plastic surgery, etc. They're all fields, and they they depend on the best minds and the best people delivering it and innovating and writing and teaching and training. I really enjoy being a part of it. There's a very nice international camaraderie. I'm a member of some international transgender care and surgery organizations, including WPATH. And it's just really nice. It's a very collegial field. We teach each other. I learn a lot from my colleagues abroad. In fact, I trained in England, and it's just a wonderful, dynamic exchange of ideas and learning. So I'm incredibly fulfilled with it. And as much as I love general urology and some of the cisgender urology I do, I'm quite happy focusing on my work in this field, which is a young, growing field. I refer to our program as an interdisciplinary program and not a multidisciplinary program. A multidisciplinary program simply offers a multitude of services, but the word interdisciplinary connotes that the people that provide those services work together in conjunction with one another. And I think that's a very important distinction, not just grammatically, but in reality, because I think a good program, everyone works together, not in isolation of one another. So, and that's what I've been dedicated to UCSF and here at Cedars Sinai since we started our program. I think it's an ideal way to organize and run a program.